Neonatal skin development follows a predictable timeline with significant clinical implications. Epidermal formation begins between 5 and 8 weeks gestation, achieving functional maturity around 34 weeks. This developmental progression directly impacts clinical management decisions. Term infants present with fully keratinized epidermis, providing effective barrier function. In contrast, preterm infants demonstrate markedly immature skin architecture. The stratum corneum in premature infants contains fewer cell layers, resulting in transepidermal water losses up to 10 times greater than term counterparts. These physiologic differences necessitate specific management strategies, including isolate humidification, minimal adhesive use, and meticulous fluid balance monitoring. The skin serves multiple integrated functions beyond barrier protection. Thermoregulation depends on intact skin integrity, with disruption leading to significant heat loss. Sensory function develops progressively, with implications for pain management and developmental care. Metabolically, the skin participates in vitamin D synthesis and demonstrates variable drug absorption based on gestational maturity. Preterm skin shows increased permeability to topical medications compared to term infant skin, requiring careful consideration of systemic absorption. These developmental differences create distinct care requirements. Extremely premature infants require humidity support, minimal handling, and careful monitoring of insensible losses. As gestational age increases, skin barrier function improves, allowing graduated changes in environmental support and handling techniques. Understanding this developmental continuum enables appropriate gestational age-specific care planning and complication prevention. For preterm infants, minimal manipulation remains the cornerstone of skin preservation. Each unnecessary touch disrupts the fragile epidermal layers and increases transepidermal water loss. When skin care is necessary, petroleum-based emollients provide effective barrier support without systemic absorption concerns. Studies demonstrate that these occlusive agents reduce water loss by up to 40% in extremely low birth weight infants, while maintaining skin integrity. The prohibition against keratolytic agents deserves particular emphasis. Salicylic acid and lactic acid, while beneficial in older populations, pose significant risks in neonates. The immature stratum corneum allows rapid systemic absorption, potentially leading to metabolic acidosis and salicylate toxicity. This represents a critical safety concept. Adhesive selection significantly impacts skin integrity outcomes. Silicone-based adhesives demonstrate superior performance in the NICU setting, providing secure attachment while minimizing epidermal stripping during removal. The hydrophobic properties of silicone reduce moisture accumulation beneath the adhesive, decreasing maceration risk. When compared to traditional acrylic adhesives, silicone products show 70% less epidermal damage upon removal. Proper positioning and movement techniques prevent shear injury. The principle of lifting rather than sliding protects the dermal-epidermal junction from separation forces. This mechanical consideration becomes especially critical in edematous infants, where skin friability increases. Each repositioning represents an opportunity to either preserve or compromise skin integrity through technique selection. These principles form an integrated approach to neonatal skin preservation, balancing necessary interventions with protective strategies to maintain barrier function throughout the NICU stay. Precise terminology in neonatal dermatology forms the foundation for accurate diagnosis and communication. These descriptive terms appear throughout certification examinations because they represent the universal language for documenting skin findings. The distinction between flat and raised lesions provides the primary classification framework. Macules and patches describe flat, non-palpable color changes that differ only in size. A macule measures less than 1 centimeter. Think of the individual salmon patches on a newborn's eyelids. When these coalesce into larger areas exceeding 1 centimeter, they become patches. This size distinction matters because it often correlates with different pathologic processes. Raised lesions follow the same size-based nomenclature. Papules, those firm elevations under 1 centimeter, commonly appear in conditions like miliaria rubra. When multiple papules confluence or a single lesion exceeds 1 centimeter, the term becomes plaque. Neonatal lupus exemplifies this progression, where individual papules may merge into characteristic annular plaques. Fluid-filled lesions require careful characterization. Vesicles contain clear fluid and measure less than 1 centimeter, the classic presentation in herpes simplex infection. Bullae represent the same process on a larger scale, exceeding 1 centimeter. This size distinction carries prognostic significance, as bullous lesions often indicate more serious conditions like epidermolysis bullosa or severe drug reactions. Pustules, regardless of size, contain purulent material. The content analysis becomes critical here. Bacterial pustules demand different management than the sterile pustules of Erythema toxicum. Hemorrhagic lesions tell their own story through appearance and behavior. Petechia present as pinpoint, non-blanching red to purple spots representing capillary hemorrhage. The non-blanching characteristic distinguishes them from erythematous macules. Applying gentle pressure reveals whether blood remains within vessels or has extravasated into tissues. Ecchymoses represent larger areas of hemorrhage, often indicating more significant vascular compromise or coagulopathy. Understanding these fundamental terms enables accurate documentation, appropriate diagnostic workup, and effective communication with consultants. Each descriptor carries implications for differential diagnosis and management decisions that extend far beyond simple vocabulary. Erythema toxicum neonatorum represents one of the most common benign neonatal eruptions, affecting 30 to 70% of term newborns. Despite its alarming name, this condition requires only recognition and parental reassurance. The classic presentation consists of yellow-white pustules surrounded by irregular erythematous halos, creating a distinctive flea-bitten appearance. These lesions typically emerge within the first 1 to 3 days of life. Though onset can occur from birth to day 14, the distribution pattern provides diagnostic clues. Lesions favor the face, trunk, and proximal extremities, while characteristically sparing the palms and soles. This sparing pattern helps differentiate Erythema toxicum from other pustular conditions. The diagnostic gold standard remains Wright's stain of pustular contents. The finding of predominantly eosinophils, often comprising 90% or more of cellular content, confirms the diagnosis. This eosinophilic infiltrate reflects a benign inflammatory response rather than infection, explaining why cultures remain sterile. The absence of peripheral eosinophilia distinguishes this localized process from systemic conditions. Understanding the pathophysiology helps explain the clinical course. Current evidence suggests an inflammatory response to commensal skin colonization in the immediate postnatal period. The pustules resolve spontaneously within 5 to 7 days, often with a waxing and waning pattern that can concern parents. New lesions may appear as others fade, but the overall course remains self-limited. Management centers entirely on reassurance. No treatment hastens resolution, and interventions may cause unnecessary irritation. Parents benefit from understanding that this represents a normal neonatal adaptation rather than infection or allergy. Documentation should emphasize the benign nature and expected resolution timeline to prevent unnecessary follow-up visits or parental anxiety. Transient neonatal pustular melanosis presents a unique diagnostic challenge due to its evolving morphology and demographic predilection. This benign condition affects approximately 5% of African American newborns compared to less than 1% of Caucasian infants, making demographic context clinically relevant. The hallmark of this condition lies in its 3 distinct phases, which may present simultaneously or sequentially. Initial pustules appear at birth or within the first 24 hours, distinguishing this timing from Erythema toxicum. These superficial pustules rupture easily, often during initial handling or bathing, leaving behind a characteristic collarette of fine scale. This peripheral scaling creates a distinctive circular pattern that aids diagnosis. The final phase produces hyperpigmented macules at previous pustule sites, which may persist for weeks to months. Wright's stain analysis reveals predominantly neutrophils, contrasting sharply with the eosinophilic pattern of Erythema Toxicum. This neutrophilic infiltrate, despite suggesting bacterial infection, occurs without pathogenic organisms. Gram stain in cultures remain negative, confirming the sterile, inflammatory nature of these lesions. The presence of neutrophils without infection represents a key certification exam concept. The distribution pattern encompasses any body surface, including palms and soles, areas typically spared by Erythema Toxicum. Lesions may appear in different stages simultaneously, with fresh pustules adjacent to scaling rings and hyperpigmented macules. This polymorphic presentation often prompts thorough evaluation to exclude infectious causes. Management requires only parental education about the benign, self-limited course. The pustular phase resolves within 48 hours, while hyperpigmented macules fade gradually over 3 to 4 months. Parents, particularly those unfamiliar with this condition, benefit from understanding that the pigmentation changes represent post-inflammatory hyperpigmentation rather than scarring. No treatment accelerates resolution, and aggressive cleansing may worsen the appearance by promoting pustule rupture and subsequent hyperpigmentation. Understanding benign neonatal facial and oral lesions prevents unnecessary interventions and provides appropriate parental guidance. These common findings appear in nearly half of all newborns and follow predictable patterns of presentation and resolution. Milia present as tiny white papules, typically 1 to 2 millimeters in diameter, affecting 40 to 50% of newborns. These keratin-filled inclusion cysts develop from retained epithelial cells within the pilosebaceous unit. The distribution concentrates on the nose, cheeks, and forehead, where sebaceous density is highest. Parents often express concern about these whiteheads, but understanding their benign nature and spontaneous resolution over several months prevents inappropriate manipulation. The differential diagnosis includes sebaceous hyperplasia, which appears more yellow and oily due to lipid content rather than keratin. The oral cavity demonstrates similar inclusion phenomena. Epstein pearls represent the oral equivalent of facial milia, appearing as white papules along the median palatal raphe or alveolar ridges. These arise from epithelial remnants trapped during palatal fusion. Bond nodules, another variation, develop from mucus gland remnants and appear on the hard and soft palate. Both resolve spontaneously within weeks to months as oral epithelium matures and sheds. Sebaceous hyperplasia deserves special mention due to its hormonal etiology. These yellow papules on the nose result from maternal androgen stimulation of sebaceous glands during late gestation. The distinction from milia relies on color. Sebaceous hyperplasia appears distinctly yellow and slightly translucent, reflecting lipid content. Resolution occurs within the first few weeks of life as maternal hormone influence wanes. This temporal pattern helps differentiate sebaceous hyperplasia from milia, which persists longer. Recognition of these benign lesions prevents unnecessary evaluation and treatment. Each represents normal developmental variations requiring only parental reassurance and expectant management. Two common neonatal skin findings, miliaria and cutis marmorata, represent physiologic responses to environmental conditions rather than pathologic processes. Understanding their mechanisms guides appropriate management and parental counseling. Miliaria develops when eccrine sweat ducts become obstructed, creating a spectrum of clinical presentations based on the obstruction level. Environmental factors, including high ambient temperature, excessive bundling, and fever, precipitate this condition. The pathophysiology involves keratin plugging of immature sweat ducts, leading to sweat retention and subsequent inflammation. Miliaria crystallina represents the most superficial form, with obstruction occurring within the stratum corneum. Clear, fragile vesicles resembling dewdrops appear on the head, neck, and upper trunk. These superficial vesicles rupture easily with minimal friction, leaving no residual changes. The absence of surrounding inflammation distinguishes crystallina from deeper forms. Miliaria rubra, commonly termed prickly heat, results from deeper obstruction within the epidermis. The clinical presentation includes erythematous papules and papulovesicles surrounded by inflammatory halos. Affected infants often demonstrate irritability due to the pruritic nature of these lesions. The distribution favors intertriginous areas and covered surfaces where heat and moisture accumulate. Management focuses entirely on environmental modification, reducing ambient temperature, removing excess clothing layers, and ensuring appropriate air circulation resolves most cases within 24 to 48 hours. Topical preparations offer no benefit and may worsen obstruction. Cutis marmorata presents as a reticulated, violaceous pattern, creating a net-like appearance over the skin's surface. This vascular phenomenon results from physiologic vasomotor instability, particularly common in preterm infants whose autonomic regulation remains immature. Cold exposure exaggerates the pattern through vasoconstriction of cutaneous vessels. The modeling blanches with pressure and resolves completely with rewarming, distinguishing it from pathologic conditions like cutis marmorata telangiectatica congenita. Documentation should emphasize the reversible nature and absence of associated symptoms to differentiate from concerning vascular abnormalities. Diaper dermatitis represents the most common skin condition in NICU infants. The pathophysiology centers on irritant contact dermatitis, resulting from multiple converging factors. The condition develops through mechanical and chemical mechanisms. Friction from diaper materials combines with prolonged contact with urine and feces in an occlusive environment. This environment promotes moisture retention, leading to maceration and breakdown of the stratum corneum. The compromised barrier function allows penetration of irritants and predisposes to secondary infection. Peak incidence occurs between 9 and 12 months in the general pediatric population. However, NICU infants demonstrate unique vulnerabilities: frequent stooling secondary to feeding intolerance, antibiotic-associated diarrhea, and challenges maintaining skin integrity in critically ill infants accelerate disease development. Onset may occur as early as 1 week of age, particularly in infants receiving broad-spectrum antibiotics or experiencing feeding difficulties. Risk stratification identifies vulnerable populations. Infrequent diaper changes increase contact time with irritants. Diarrheal illnesses exponentially increase exposure to fecal enzymes. Antibiotic therapy disrupts cutaneous microbiome balance, facilitating pathogenic colonization. Recognition of these factors enables implementation of preventive protocols before significant dermatitis develops. Anatomical distribution provides diagnostic clarity. Erythema localizes to convex surfaces, maintaining direct diaper contact: buttocks, genitalia, and upper thighs. This distribution reflects the mechanical and chemical insults driving the inflammatory process. The pathognomonic finding, distinguishing irritant dermatitis from other conditions, involves sparing of intertriginous areas. Protected skin folds escape the friction and chemical exposure characterizing this condition. Involvement of skin folds necessitates immediate consideration of secondary infection, particularly Candida. Disease severity exists along a defined spectrum, guiding therapeutic intervention. Mild disease manifests as scattered erythematous papules without significant discomfort. Moderate disease demonstrates extensive erythema, with maceration causing irritability during diaper changes. Severe disease develops a characteristic glossy appearance, with painful erosions and nodular changes, causing significant distress with manipulation. Jacket erosive dermatitis represents severe chronic disease. Well-demarcated ulcerations with punched-out morphology develop from prolonged exposure, particularly in settings with suboptimal hygiene. While uncommon in modern intensive care settings, recognition prevents diagnostic confusion with infectious processes or non-accidental trauma. Secondary Candida infection represents a common complication requiring distinct management. The temporal criterion for suspicion involves persistence beyond 72 hours despite appropriate barrier therapy. Morphologic features distinguish Candida from simple irritant dermatitis. Unlike primary diaper dermatitis with fold sparing, candidal infection preferentially involves intertriginous areas. Characteristic findings include erythematous plaques with satellite papulopustular lesions extending beyond primary borders. Pustule rupture produces the pathognomonic collaretive scale, a peripheral rim of desquamation confirming diagnosis. Predisposing factors create conditions favoring fungal proliferation. Antibiotic therapy eliminates competitive bacterial flora, permitting Candida overgrowth. Concurrent oral candidiasis indicates systemic colonization. Diarrheal illness provides optimal growth substrate through increased moisture and pH alteration. Clinical diagnosis typically suffices, giving characteristic morphology. Potassium hydroxide preparation demonstrating pseudohyphae provides confirmatory evidence when diagnostic uncertainty exists. However, empiric therapy remains appropriate when clinical features strongly suggest candidal involvement. Early recognition impacts therapeutic outcomes. Barrier preparations alone prove ineffective against established fungal infection. Prompt initiation of antifungal therapy reduces treatment duration and prevents progression to more extensive disease. Evidence-based management prioritizes barrier protection as the fundamental intervention. Zinc oxide preparations create mechanical barriers between skin and irritants. Optimal application involves thick layering to ensure complete coverage. Partial removal during diaper changes, rather than complete cleansing and reapplication, minimizes mechanical trauma to healing epidermis. Petroleum-based products provide additional occlusive properties, particularly beneficial for infants with frequent loose stools. Layering petroleum products over zinc oxide maximizes protective effects through complementary barrier mechanisms. Cleansing protocols vary based on gestational age and skin integrity. Infants exceeding 1,000 grams with intact skin tolerate fragrance-free, alcohol-free cleansing wipes. Extremely premature infants with compromised skin integrity require water-based cleansing with minimal friction. Mineral oil facilitates removal of adherent barrier products without mechanical trauma. Contraindicated practices include excessive mechanical cleansing, which disrupts healing epithelium. Powder application poses aspiration risks without dreamed benefit. Harsh cleansing agents remove protective lipids and alter skin pH, potentially worsening dermatitis. Preventive strategies emphasizing frequent diaper changes, consistent barrier application, and appropriate cleansing techniques reduce progression to moderate or severe disease. Therapeutic interventions correlate with disease severity. Mild to moderate presentations respond to increased diaper change frequency combined with consistent barrier preparations. Resolution typically occurs within 48 to 72 hours when causative factors are eliminated while maintaining skin protection. Severe disease necessitates multimodal therapy. Dermatology or wound care consultation optimizes management of complex cases. Hydrocortisone 1% cream, applied twice daily for 3 to 5 days, reduces inflammation without significant risk of cutaneous atrophy or systemic absorption. Barrier preparations applied as the final layer maintain protection while optimizing medication contact. Candida superinfection requires targeted antifungal therapy. Topical azole preparations demonstrate efficacy when applied 2 to 3 times daily beneath barrier ointments. Treatment duration extends up to 14 days to prevent recurrence. Sequential application ensures antifungal contact while maintaining protective barriers. Systemic manifestations warrant immediate evaluation. Fever or constitutional symptoms accompanying diaper dermatitis suggest bacterial superinfection. These presentations require bacterial cultures and consideration of systemic antimicrobial therapy. Rapid progression from cutaneous breakdown to sepsis occurs in immunocompromised NICU populations. This algorithmic approach standardizes care while allowing individualization based on severity and complications. Evidence-based protocols ensure appropriate treatment intensity while avoiding unnecessary interventions in uncomplicated cases.